Welcome everyone to today's webinar organized by the Reproductive Health Supplies Coalition Youth Caucus. We will begin momentarily, but still await a few people for joining. But I will already start with the introduction. So my name is David. I'm the Interim Advocacy Officer at the Reproductive Health Supplies Coalition. And this is the first webinar in a series of two, where we will be presenting where the grantees from the Youth Innovation Fund round will present their results. So through a grant from the David and Lucile Packard Foundation, the Reproductive Health Coalition sought to draw attention to the reproductive health supplies need of young people and to confront the barriers that impede their access. So in September 2016, the coalition launched its first youth-specific innovation fund round to inspire and fund new initiatives that address and advance youth access to reproductive health supplies. And this first call yielded a total of over 30 grant applications. And from these, 4 projects were chosen to receive a one-year grant. And now that these grants have been concluded, the grantees will share their results, their findings, and their lessons learned. So today we are joined by 2 organizations, WoMena, who in Uganda have evaluated the effectiveness of 6 innovative pricing, distribution, and payment models in delivering menstrual cups to youth, age 50 to 30, through NGO and private sector distribution channels in rural and urban settings. And we're joined by MSI China, who tackled high abortion rates and limiting method mix among adolescents by developing and introducing in 6 hospitals the country's first service delivery guidelines for youth access to long-acting reversible contraceptives. We thank you for joining us on this rather odd hour, but that is to respect the time difference with China. And know that all the recording and all presentations will be shared afterwards. Instead of having a Q&A at the end of the webinar, we will have a Q&A moment after every presentation in order to respect the late hour for the Lily Liu, who is the country director of MSI China. And she will be presenting first. After that, it will be Laura Haiti, I hope I pronounced her name correctly, who is a research and project coordinator for WoMena Uganda. You can pose questions by raising your hand or posing questions in the message box. And you can always, if you have a question afterwards, email us with your questions so that we can contact and connect you with the speakers. So the first presentation is from Lily Liu from MSI China. So I'm going to put up your presentation.
Thank you, David, for your introduction. And hello, everyone. Good morning, good afternoon, good evening, and good day. I am the country director of Maristop International China. And we are very happy to be here and to talk to you, to share our experiences in implementing of this very innovative and new project supported by RHSC. Yeah, I still can't see the screen.
Can you see it now? You should be able to see it now.
No, sorry. Yes, I can see now. Yeah, thank you. So next page, please. Now, first, I would like to start by saying why youth and LARC in China. Maybe you are all aware in China, we have a lot of unwanted pregnancies and abortions. So every year in China, we have about 13 million abortions. And among these 13 million, almost close to 50% are for women aged 25 and under, so younger population. And then also among of them, close to 50% are for unmarried. And what is more than 50% are repeated abortions. And why these are the figures are so high? And because, you know, among young people in China, and condoms, withdrawal, and calendar methods, plus emergency contraceptions are most popular methods among young people. So you can see these methods are not very reliable methods. And in China, LARC use for unmarried young people almost non-existent, because young people don't have information or don't have the knowledge about the LARC, and they have a lot of misconceptions on LARC. And most of the young people believe LARCs are only for moms, for women who have children and who are doing postpartum family planning. And at the same time, the service providers have bias, and they believe and LARC are for married people, not for unmarried young people. So these are the situations in China. So that's why we think it is important, if we want to reduce the abortion numbers, and LARC should be introduced. Next page, please. Yes, what we have been done in this project, and from supply side, what we have done mostly 3 things. One is to translate and publish a number of international documents supporting use and LARC to raise awareness among service providers and professionals. So these we have translated more than, I think, 4 documents. This is just one example, global consensus on expanding family planning service choices for young people, including LARC. So it has been translated and published in China journals, and so that a lot of service providers can read it and begin to understand that LARC is not just limited to married people, and young people can get access to LARC. So next page, please. And the second activity on the supply side, what we do, we have been working with national experts and to have developed the guidelines for youth access to a full range of contraceptives in China. So this is the guidelines. It has been going through several rounds. So first we have a group of experts set up, and then they have drafted the guidelines, and then the guidelines has been discussed and tried out in pilot hospitals, and then it has been discussed again. So that's the guidelines we have been developed. And then next important thing we do is we use these guidelines and to try it in pilot hospitals. Next page, please. So we test the guidelines in 6 pilot hospitals, and at the same time, these 6 hospitals, pilot hospitals, beginning to provide LARC services for married young people. So these 2 photos are, the first photo is really the launching of these pilot hospitals. We have 6, and another one, the one below, is the training for these pilot 6 hospitals on use and LARC. Next page, please. So that's what we have been doing for from supply side. And at the same time, we think it's very important and to have activities from demand side with young people. Now, David, it's wrong now. It's coming back to the cover page. Can we go to the demands? Yes. And so for the young people, especially from demand side, awareness raising activities, and we have carried out a number of activities. For example, we have developed different IEC materials for use and LARC. So the examples are posters. And then we have developed animation video named LARC Makes LARC. And so it's only 4 minutes, and then young people can see it on their mobile phones, and then it talks about LARC. And then, of course, we have had educational sessions, training sessions, discussions with young people about LARC and family planning and a variety of choices. So these are all the different activities we have been doing from demand side. So let's see what are some of the results after trying it for almost a year. Now, next page. So these are some of the initial results. And so we tried it in 6 pilot hospitals, starting from this last year, from January 1st to July 31st of 2017. So in 6 hospitals altogether, more than 18,000 surgical abortions have been carried out. So among them, 20%, 21.15% are for women and 25 years old for young and married people. And among this group, 544 LARC has been provided. And so that has really interesting because, you know, LARC has been almost in no existence. And so because of this project in these 6 hospitals for unmarried young people, so we have been able to increase the use of LARC for unmarried young people almost from 0 to 13%. And what is more encouraging is additional, you know, in this project, RHSC has been supporting $50,000, but we have been able to generate additional $85,000 and to continue the pilot practice in 6 hospitals, and at the same time, and to support 8 operational researches relating use and LARC. And the use, now, you know, in China, we have China Medical Association, and within China Medical Association, they have different subcommittees. And within a family planning committee, they have a youth expert group. And so for this youth expert group, they have already been taken use and LARC as one of their operational and advocacy priority topics since last year, and they are still doing it up to this year. So actually in China, we are going to have a 14th National Family Planning Conference in late April in Tianjin. So it has been already decided in this conference, an introduction to the 8 use and LARC operational researches will be presented. And at the same time, a new round of operational research applications will be announced, and with a further new funding of $50,000. So all these additional fundings are coming from local resources, from local companies, and from local foundations. So these are some of the positive sides. And there are, of course, challenges. For example, there's still quite limited access to LARC products. Now in China, when we talk about LARC, and then mostly people will think about IUDs. Yes, IUDs are most available. But implants, we do have sinoplants, and we do have implant. But both sinoplants and implant are used very, very few, and not many hospitals are using them or having these products in their supplies. And that's one challenge. A second one is for unmarried young people. When we're trying to introduce LARC services, because LARC services in China, it has been regarded as kind of operations. So then they need signature. For unmarried young, and then especially young people below the age of 18. So there's still requirement for parent to sign on the informed consent. So that's definitely a constraint or a barrier for young people to get access to LARC services. And you know, China is such a big country, and then service providers, now, you know, we have only tried in 6 hospitals, but there are so many service providers, they have no ideas about LARC, and they still are very much biased towards LARC. And finally, for young people in China, and they don't have a lot of information about LARC, and they don't even have good awareness on their own sexuality. So, you know, in China, we don't have a good sex education. So are all the challenges we are facing. And that's also the lessons we have been learning from the implementation of this project. So finally, what I would like to say, this project has been really served as a very important, a very first step in China to introduce LARC to the young people. But there is still a long way to go. So we hope that we can go together. Thank you very much. So
Thanks,
if you
Lily.
are having any questions, I will be very happy to have discussions and also to learn from your experiences and, of course, your suggestions.
Yes, thank you, Lily, very much for joining us, especially given the late time now in China. And I think that are very impressive results and very interesting findings to take away as a first step. So is there anybody who has a question for Lily?
Maybe it's either too early or it's too late.
No, I have a question.
Okay, that's good.
So there is a question from Diana Sierra who asks that are the LARC products being given away for free, or are there need to be procured by the young people who want to receive a LARC product after the abortion?
I think it's a little bit complicated situation in China, but in most cases, the services can be covered by health insurance, but not 100%. Certain percentage will be covered by health insurance. And then the young people, certain percentage, young people will have to pay out of their own pocket.
Okay, thank you. So I have another question from Chadia, who would like to know why that the product did not include short-term methods, or why that there was only a focus on LARCs.
So the short methods are good, but then because sometimes the failure rates are higher, and then that's partly contribute to the large number of unwanted pregnancies and resulted in abortions. So that's the reason we want to introduce LARC and to not to change, and actually to expand the choices. So young people can have more choices, and if they have a steady relationship, if they decide not to have children for quite a long period of time, and the LARC can be a choice rather than always relying on not very reliable, especially those methods like calendar methods and the withdrawal and those things. That's the reason.
Okay, thank you. And then we have another question from Mariana, so I'm going to unmute you, Mariana. Can you hear me, Mariana?
Oh, hi. I might missed what you presented, but I wanted to know if LARC are only offered after abortions or also to adolescents who gave birth.
Right now, yes, for adolescents who have been given birth, that's pretty easy and easily be doing in China. And what's more difficult is for those young people who are not married and who are having abortions. So that's the more challenging to do. So yes, both are offered to adolescents who are having been abortions and to those who have had this.
Okay, but the focus of the project was on those who had abortions.
Yes.
Okay, thank you.
So I also have a question. So like you said, the focus of this project was including Larks in post-abortion services. And given that you are able to continue the project with new funding, is there the idea of maybe including Larks in other services provided in the hospitals related to family planning services, or is the focus going to keep being on Larks in post-abortion care?
No, it's also the idea is to expand not only just for post-abortion care, but also for it's a kind of a choice, so that young people, if they want to have it, and then they can go and for it, rather than just as a post-abortion method now. So we hope it can expand the choice, and then it's readily available in the places where young people want to go.
Okay, thank you. And then I have two final questions. One from Betiana. Her question is if young people can access Larks with insurance coverage without parental consent.
It's if their age is over 18 and they can sign on their own. But if they are below the 18, now we have difficulties. So it's now up to the implementation of the specific hospitals. And some hospitals will ask at least someone who can sign on it. And maybe it's their parent or maybe it's their friend. But some hospitals will stick to the rules. They want to have parents to sign it. So that's a barrier for some of the young people.
Okay, thank you. And then a final question from Mukisa Davis. So he says that in Uganda, most of their work around family planning is hindered by religious and cultural leaders. So who are in China, or what is in China the main opposition to Larks, and how do you think it will be able to overcome opposition to abortion and post-abortion care?
In China, religion is not a big issue in China in terms of response to abortion services, in response to family planning services. And in China, the biggest challenge is, first of all, the awareness of the service providers, and they don't believe that Larks should be offered to unmarried young people. And secondly, the young people themselves, they are not aware that they can use Lark and to practice family planning. So the biggest challenge in China, maybe it's a little bit different from Uganda. So it's mostly service providers as well as young people's own knowledge. And of course, lack of information, lack of awareness, that's the biggest thing.
Okay, and so we have another, maybe a final question. It's from Mariana. She asked if which Lark are being offered in the program, and was there a difference in terms of acceptance or preference for implants and IUDs?
Right now, in these 6 hospitals, mostly IUD have been offered, and implants, because implant is not readily available, although it's available in China, but then it's out of stock. So hospitals sometimes do not have that stock. So mostly it's IUD. But now we are trying very hard and to introduce implants, and so that young people can have another choice, not only IUD but also implants.
Okay, thank you very much. So if anybody else have in the future a question on MSI China's work on Larks, and and the project, you can always email me and we will forward the emails to Lily. So thank you, Lily, for joining again. We are now able to move on to the next presenter, which is Laura. So Laura, go ahead, the floor is yours.
Great, fantastic. Thank you very much, David, and thank you, Lily, for an excellent presentation. It's really great to hear the amazing work and how well the project has gone. So well done, congratulations. So my name is Laura Haiti, and I am research coordinator for WoMena Uganda. We are an NGO working primarily in Uganda with menstrual health, both from training and advocacy as well as product distribution, and working mainly with partners on the ground. And we received the Reproductive Health Supplies Coalition Innovation Fund grant about a year ago to test and promote menstrual cup sales in Uganda. So in terms of menstrual health in Uganda specifically, there is generally a lack of access to acceptable, affordable, and safe menstrual health management products for girls and women. And this often leads to girls and women utilizing unsafe and uncomfortable materials that can really have an impact on physical, social, and mental well-being. This is often products such as pieces of mattress, socks, cloth. We've heard reports of girls using school notebooks, and really does have an impact on both girls and women's mobility and their dignity in terms of managing their menstruation. The menstrual cup is a medical grade silicone cup which is inserted into the vagina and collects menstrual fluids. And dependent on the brand, it can be reusable for up to 10 years. WoMena has been working with menstrual cups in Uganda since 2012, starting very small and gradually growing. We've distributed just above 3,000 menstrual cups. And most of that distribution has been on a donation basis, which obviously has sustainability issues in terms of sustainability. What we've also noted in much of our work is that as we work with communities and with girls and women to provide menstrual cups for free, we are also creating demand. And it's unmet demand because there really is no access to menstrual cups, or hasn't been any access to menstrual cups in Uganda broadly. There are some pharmacies that sell menstrual cups in Kampala, but at a fairly high cost of approximately around $22, which for a majority of Ugandan girls and women is prohibitive. So this project really kind of got its start from us recognizing this unmet need and wanting to really build a more sustainable market option within the Ugandan context. So the project objectives really were to integrate menstrual cup pricing, distribution, and payment models into existing partner service delivery. So this project really aimed at not creating new infrastructures, but utilizing those infrastructures that are already in place and utilizing the expertise of our partners on the ground as well. We also aim to evaluate these models for effectiveness and feasibility, very much geared towards future scale of these models, and for lessons learned for other organizations that might want to look at scaling up sales. And thirdly, we also aim to promote a policy environment that is conducive to effective supply and distribution of menstrual cups in the Ugandan context. And we worked with three main partners. So we worked with Beltunga Hilfe, which is an NGO working mainly with food security, but has also for a long time been working with menstrual health and has previously worked on a small scale with menstrual cups in Karamoja, which is up north in Uganda. We also worked with Mary Stokes Uganda with 3 different programmatic elements that they have. With Buffalo Pharmacies, which is an independent private pharmacy, as well as ASEM Pharmacy in Kampala, and Ruby Cup, which is a menstrual cup producer and distributor, has very generously donated the menstrual cups towards this project. and we also received support from Sejeki, which is a social marketing company that has provided us with pro bono marketing support in terms of designing our marketing materials for demand creation on the project. So really what we looked at was 6 different pricing and distribution models. So with Welthungerhilfe, we had our first model is the Goat and Cup for Work scheme, which essentially is not a kind of a sales model per se, but it is a cash in kind model, where girls and women in Karamoja are able to sign up for a kind of cash for work scheme where they work 16 days towards a goat, and then a further 4 days towards a menstrual cup. And the price was set at $4 for the kind of the equivalent, so $4, approximately $1 a day per work. We also had a savings group model, which we started testing within rural savings groups, but we're not very successful there. So we recently, towards the end of the project, switched to working with urban savings groups, selling the menstrual cup directly to savings groups at about $7. We had 3 different models with Mary Stopes. The first is the Mary Stopes Ladies. So Mary Stopes Ladies are nurses and midwives who work with family planning within their communities. So they essentially get training and a basket of goods from Mary Stopes and sell those services directly within their community and are able to make a profit from those sales for themselves. And we essentially added a menstrual cup to their basket of goods. And so the Mary Stopes Ladies have also been selling the menstrual cups at a price that is acceptable to them, but capped at approximately $7. We also attempted to have sales through Mary Stopes clinics. So Mary Stopes has 15 flagship clinics in Uganda, and we tested sales in 5 of those clinics. And then later on in the project, we also added a cohort of youth ambassadors who are young people who work specifically with youth, raising awareness about sexual reproductive health, conducting referrals. And so we also added the element of them acting as salespeople for menstrual cups, particularly due to their access to young populations, but also to provide them with a source of income. And then the 6th model was looking at menstrual cup sales within pharmacies in Kampala, so the pharmacies that were already selling menstrual cups, and also at the market price that they are selling them at, which is about $18 to $22. Yes, so in terms of the success of those models, we definitely had 2 models that definitely stood out, and that was the Mary Stopes Ladies model, as well as the Welthungerhilfe Cups and Goat for Work model. Across the models, essentially, we provided a number of inputs. So we trained 171 partner staff, sales agents, and community facilitators across the different sales models. We also provided a number of different types of materials. So we developed demand creation tools, posters, flyers, t-shirts, as well as kind of guidelines and booklets for the salespeople, each kind of modified slightly to the context. We also provided kind of demand creation support. So basically, we utilized existing structures that our partners had. So Mary Stopes, for example, has a fully fledged demand creation department that has integrated demand creation both into the kind of very low-level community-based demand creation by the Mary Stopes ladies themselves, by the youth ambassadors, and then slightly bigger demand creation. Welthungerhilfe also developed a menstrual cup song, so a song that was developed in collaboration with women in one of the communities that we're working with, and a local musician, which has been a real hit and is very popular among the women in the community. And one of the great things about that was actually that it was initially written by the local artist, and when the women in the community heard it themselves, they actually said, you know, actually this is too modern for us. This is not the type of music that we really like, and they rewrote the song together with the local musician. So that it was a very participatory process in terms of creating these demand creation tools. And in addition to that, in Karamoja as well, the women themselves created a logo, which is a clean woman every month in Karamojong, which is something that we've replicated across all the marketing materials. So in terms of inputs, we also received 1,605 donated menstrual cups for the project. We actually started out with 285, which was based on an estimate from our partners in terms of what we thought we would be able to sell. So, you know, we've significantly superseded our expectations in terms of the actual sales. And essentially what we ended up with was 1,227 menstrual cup sales. A majority of those were through the Goat and Cup for Work scheme. So we had 893 sales through the Goat and Cup for Work scheme. And we had 318 sales through the MS Ladies. So as I said earlier, those were definitely our two most successful models. In terms of the other models, we had less success. So youth ambassadors, we'd only had 6 sales, but that's because it was added recently. We had very low sales within the MS clinics, very low direct community sales, and only 3 pharmacy sales. But overall, we kind of vastly superseded our expectations in terms of the amount of sales we would have. This is just an example of some of the marketing material that we put together. So you can also see the Karamojong logo. It's also Nancy, who is our menstrual health coordinator in Karamoja, who is now kind of cordially known as the cup lady among communities there. In terms of the results, so in terms of the beyond the sales results, we also really felt it was extremely important for us to understand not just whether the cups were being sold, but what the experience of the users were. The target age group for this project was 15 to 30, and we reached 79% of the cups were actually sold to young women and girls aged 15 to 30. And 34% of these sales were to girls between the ages of 15 and 24. But it is worth noting that actually overarchingly the mean age was 26. And so with the Mary Stokes model, we had a far higher age group than with the Weltungen Hilfe group. So majority of the younger girls who received cups or purchased cups are actually through the Weltungen Hilfe model, where they were not actually physically paying for those cups. It is also, however, worth noting that we had a fair amount of sales of parents and grandmothers, particularly, either working for a cup for their daughters or granddaughters, or purchasing cups through the MS Lady model. And we weren't able to capture all of that data, so the age range might be a little bit misleading, and we do actually think that we had a higher number of sales to younger girls through parents and grandparents. The qualitative end line shows a very high level of satisfaction among the cup purchases. So a majority of women and girls that we interviewed who had purchased cups were very happy with the information that they'd received. We're very happy with having this peer exchange where they got all the knowledge they needed to utilize the cup, and were able to also get continued support if they had difficulties using the menstrual cup. Also, based on our qualitative interviews and focus group discussions, we found that there was a kind of a high level of safe use practice. So when girls and women recounted to us what they were doing when they were using the menstrual cup, disinfecting between their periods, making sure they had clean hands, not utilizing chemical products, they were utilizing the cups according to the safe use guidelines. But actually, when we conducted knowledge retention tests, we found that there was a perception that, for example, you should be using chemical products. So there's a little bit of a mixed mass in that, and definitely indicates that there needs to be more refresher training, and we need to work on how the information about safe use is disseminated. It's also worth noting that in Karamoja, among the Cup and Goat for Work scheme girls and women, approximately 50% of the girls and women that we spoke to in focus group discussions and interviews were not actually actively using the cup at that point in time, mainly due to pregnancy and breastfeeding. But almost 100% of them said that they wanted to utilize their cups once they started menstruating again, and that's something that we really need to follow up on with time. The key finding, however, I think, is that our peers, sales agents, and facilitators have been key to all the success. Sharing personal experiences of menstrual cup use, sharing experiences of people that they've sold menstrual cups to, and building a very trusting and kind of comfortable environment to discuss menstruation and menstrual cup use has been key to sales. And we also find that particularly those MS ladies, for example, who have had high sales, also report having very comfortable relationships with the people that they've been, with the community members that they've been working with. We also had in Karamoja, we trained a cohort of community facilitators, and this is Joyce, who was one of our community facilitators. And I just have a quote here to kind of exemplify the level of that interaction. So Joyce was trained in menstrual cup use, received one herself, and has been promoting the cup in her community. And she basically says that the menstrual cups have, first of all, changed myself, and people have seen this. I showed them how it works. We worked in the field up to 1 p.m. Then we went together to check, 13 of us in the house. I removed the menstrual cup and put the blood in a basin and poured it in the latrine. They saw everything. They see that I am smart. We are now all smart. No smell, even these old ladies. Even men can tell the women, go use a menstrual cup. So one of the things we've seen specifically in Karamoja is a real increase in engagement from men in discussions on menstrual health, and a lot of support from local communities, local leaders, and men in that area. In terms of kind of what we've learned, we've identified a number of barriers and drivers for extending access to menstrual cups in Uganda. And certainly there is a lot of contextual poverty, and particularly in Karamoja, a lot of food insecurity. So, for example, what we saw within the rural savings groups is that although there was an acceptance and a level of kind of demand for menstrual cups, women just simply did not have money. They were basically lacking in funds to feed their families. So I think this very much points to what we have been looking at, is how do we segment the market? And that is something that we don't have a full understanding of yet, but certainly recognize that sales need to work hand in hand with donations, and we really need to understand which populations to target and when. Of course, there are also cultural sensitivities, and it's a very unfamiliar product. We've noted that in all of our work that we do, and as such, there is a longer adaptation time. That was not anything unexpected for us, but certainly also showed in how long it took in some of the communities that we were working in to build that acceptance and trust in the product. We did also experience some fractured record keeping and price tracking across the models, and that is very much related to some of the programs that we were working with. For example, the Mary Stopes Ladies program being a very fresh and new program. It actually only just started in February last year. And so we definitely need to look at how to more effectively kind of track sales and prices. And also, we still have a high import and supply cost of menstrual cups in Uganda. In terms of drivers, flexibility in pricing, allowing salespeople really to the sales agents in the communities to select the price at which they're selling menstrual cups. Also to build demand in the beginning when the cups are less familiar. The trusted, motivated, community-based salespersons have been absolutely key. We now have a growing cohort of locally experienced users who can share the information, and we also have stronger demand creation networks. And basically looking forward from here, we have buy-in from both Welthungenhilfe and Mary Stopes who wish to continue expanding menstrual cup sales. We are reaching out and identifying other networks that we can expand into, particularly utilizing the lessons learned that we've had from the face-to-face, peer-to-peer interaction. We're also looking at pooled procurement to bring down cost, stopgap subsidization to ensure that we can meet the price levels that we've set as a part of this project, and also kind of further looking at effective market segmentation, as well as diversifying our demand creation approach. We had very local level demand creation, and there's definitely been an identified need for more broader national level marketing. So I'm going to leave it at that because I'm probably over time. One of the things that we're also looking at is actually starting to build a community of practice for market solutions for menstrual health products and solutions. So I'm putting a little plug in here, but if there are any organizations that are working with market-based solutions, we would certainly want to get in touch and start building a kind of a joint community where we can learn these lessons, because globally there's a lot of work happening in silo, and I believe that a lot of the lessons that we've learned from this project can be applicable to a lot of other contexts as well. So please feel free to get in touch. Yeah, that's it for me. I'm happy to take any questions.
Thanks, Laura, for the presentation and very thorough presentation. So before, so people can already raise their hand and pose a question, but I have a question as well. So I don't know if you kept record of this in any way, but from the people who purchased the cups, how many or were mostly like new users who weren't using a contraceptive method, or were there also people who were using a different type of contraceptive method and changed, or because of this initiative, or started using a menstrual cup as a test because of this initiative?
Sure. So unfortunately, that was something that we were hoping to be able to track. We haven't been able to access that data for this project. Still working on it. I'd say that in Karamoja particularly, there's very low levels of any kind of family planning use. And from our qualitative data, we can see very clearly that almost none of the users are on any kind of family planning methods. In terms of the Mary Stopes sales, there were return customers. So some of the customers who the Mary Stopes ladies were actually people that they had seen for family planning. So there's a far higher percentage for the Mary Stopes ladies, but that is also expected because actually their primary kind of contact point is family planning. I don't have exact figures on it. It is something that we kind of hope to further look into within the data. But certainly with Mary Stopes, we expect that it's a fairly high number because that's their first point of contact anyway. Okay,
thanks. I have a question from Evan, who would like to know if you could expand a little bit more on the Goat and Cup Cash for Work scheme and why you think it was more successful than the other methods.
Sure. So the Goat and Cup for scheme, basically, Welthungenhilfe already has kind of like an emergency funding that they get in times of drought when there's food insecurity. And they run a number of different types of schemes where community members, both men and women, are able to join a kind of a farming group, for example, or take part in building a well or so forth. And they either get paid in cash or in kind and also receive food as a part of that kind of interaction. So essentially what we did was add on 4 days of work for the menstrual cup. And people get recruited for this through their standard processes. And what Welthungenhilfe basically added was an additional information session on menstrual health, to recruit women onto the scheme. And we actually, there was so many people who wanted to join that we actually had to stop because we didn't have enough donated cups. So kind of it works on the premise that they get an initial information session, and then once they collect their goat and menstrual cup, they also receive a kind of information session on the safe use. We also trained community facilitators who themselves have menstrual cups and are able to share their personal experiences. So what we've seen across the board in this project and in our other work is that there is a level of mistrust in the product, and the sooner that you have someone who is a peer and from within your community who can explain to you their experience of using the cup, we have far higher buy-in. I would say that in terms of sustainable, I think the community facilitator element has been very crucial for bringing in women and girls to sign up. The demand creation has also been very successful. So the menstrual cup song has been really popular and has really been able to kind of bring the women together in the communities and kind of build interest. I think the acceptance that has gradually grown among male community members has also impacted women's kind of openness to take part in the scheme. I would note that from a sustainability perspective, this is a program that is dependent on emergency funding. So Welcome Youth, for example, really wants to continue looking at the savings group models and taking the lessons learned from peer facilitators to add into promoting more sustainable sales mechanisms. I hope that answers the question.
Yeah, of course. So Marianne, I actually also asked a question about the facilitators, as they seem to be a key actor in the program. So if you could tell a little bit more about the training, specifically what was all part of the training that you provided.
Sure. So we have a kind of very structured training model that we implement across our donation projects anyway. And what we basically did was we modified that for a sales context. So it's basic training in menstrual health, basic training in a variety of menstrual health products, and then specific training on the menstrual cup, and then a sales model where we basically talk about how to best promote the menstrual cup, what are the expected expected challenges, and that's really done in collaboration with the participants, so with the trainees, for them to really identify what they expect to be the challenges within their communities, and for us to kind of together come up with solutions for that. Slightly different for the MS ladies, for example, and the pharmacists, and then the community facilitators in Karamoja, because of a different level of prior understanding and knowledge in menstrual health. So for the community facilitators, these are our local women from the communities, and they received a two-day training, basically covering all the different aspects of menstrual health and sales. And a lot of it was interactive. So we came up with the slogan for the marketing material and so forth as a part of that as well. And then we've also gone back and done a refresher training. And we actually, one of the things that we identified in our end line was that the community facilitators did not always have access to the information that they needed. So we actually did a further kind of refresher training at the end of the project, and also provided them with more tools to help them provide the right information to remind them of the safety guidelines.
Okay, thank you. And I also have a question from Diana, who has actually two questions. So did you track the use of the product over time, or have past use consumer feedback? And what is the biggest driver of the high cost of the cups in Uganda? Is it the manufacturing cost, the import tax, or the volume of the purchases?
Sure. So in terms of cup use over time, we know that it can take anywhere between 2 to 6 months for girls and women to start even considering using the cup, especially if they get it for free. So what we have actually seen within this project, based on the interviews and focus group discussions that we did, is that when girls and women were making the decision themselves to put either money or time into acquiring the menstrual cup, they were much they were kind of more likely to start using it during their next period or fairly soon after they received it. So that's a difference that we've seen in terms of kind of donated menstrual cups. But because the adaptation period is quite long, and this project was ultimately only, and we also kind of implemented in stages. So we did have some girls and women who received, cups at, 10 months, well, about 8 months ago. And then we had some which actually, when we went to do end line, had only received their cups about 3 months ago because there was a staged implementation. So generally with menstrual cups, it is really important to have a longer term follow-up. That is something that is missing within the field. Totally, not just within this project, but generally within kind of work with menstrual cups. We estimate the cost effectiveness of menstrual cups on the basis of long-term use, but we don't have that data or evidence yet. And then just in terms of the high cost, there's a number of factors. Number one, we're talking about very small import quantities. So because the market is still, and the market demand is very small at this point, we're talking about importing small quantities. That drives up cost. We actually, just as a part of this, part of this project and other work that we did, we working with an organization called Eco Options that does commercially import menstrual cups into Uganda. We actually petitioned for a tax, for the tax on menstrual cups to be, or the VAT to be removed, and that was successful. So that we're hoping will have an impact on cost. Also, I think there needs to be more diversity on the market. At the moment, Ruby Cup is one of the only menstrual cups provided in Uganda. What we really want to see going forwards is a diversification of the cups on the market, and also looking at lower cost options.
Thank you. And then as a final question, I see that Evan has raised his hand. So Evan, I'm going to unmute you now.
My house helper, and she's like, but then you're no longer a regular. Yeah. No, not really. So
hi, Evan.
Hi.
Please go ahead.
Sorry, I don't know why we're on audio.
Okay, because you raised your hand, so maybe that was by accident.
Okay.
No problem. So then I would like to use the remaining minutes to thank both Laura and Lily, and also remind you that on Monday we will have the second webinar in this series, where the other two grantees, Village Reach and a collaboration between Fundación Escuet and CEDES in Argentina, will talk about their project called Donde. So I will reshare that invitation, but it was also, the registration link was also included in the first invitation. So that will be on Monday at, I don't have the hour, but I think it's at 9 a.m. Washington time, 3 p.m. Brussels time. So yeah, so that keep that in mind, and we hope you will also be able to join us for that webinar. I have one last question. So on very young girls between 11 and 14, do you also recommend cups or see the possibility to implement other reusable options?
So I think really menstrual cups are usable by anyone. I think one of the biggest things that we have working with younger girls, and we have worked with younger girls, we've worked in primary schools as well, is the question of virginity. We address that by trying to raise awareness and share knowledge about the anatomy and the hymen, and kind of try to disassociate virginity from the anatomical kind of tearing of the hymen. But certainly it is something that needs to be very contextually contextualized. So there needs to be acceptance from the community for menstrual cups to be provided to younger girls. And so we do work kind of closely with communities as well as to gauge that and to see what approach we can take. What we do see in younger girls is a longer adaptation time. So it's usually, understandably, there's more kind of fear in terms of starting to use the menstrual cup. So it takes girls a longer time to kind of find the courage essentially to give it a go. And it does need more support and kind of reassurance that you know, it's fine to try a menstrual cup. And ultimately it should be about choice. So we organizationally also work with reusable pads, for example, and where that is contextually relevant, then it's always recommendable to provide choice. Younger girls should be able to make a decision for themselves in terms of what type of menstrual management method they want to use.
Okay, thank you for that final response. So thank you, everyone. We are at the hour, so we will stop here. We will make the recording and the presentations available as soon as possible. And if you have a question, feel free to still email us so that we can contact you with Laura and Lily. So thank you again and have a lovely day.
Great. Thank you, David.